All right, as everyone is coming in, again, I want to thank everyone for showing up and joining and sharing space with us today. I want to take just a moment to ensure that everyone in the audience is ready and comfortable with the technical aspects of the webinar. As you will see, there's closed captioning that's enabled for today's event. We will also have American Sign Language capabilities enabled in this meeting as well. You can activate that by clicking the interpretation icon on your Zoom navigation bar. And if you need to tech support during today's event, please just use your chat, excuse me, this morning. Just use your chat message and you can respond directly to the host and we'll address any tech issues or difficulties that you may have. So lastly, if you have any questions during the presentation, there will also be the Q&A area. You guys said some issues. Are you guys able to hear me or see some comments in the chat? No volume. Okay. All right. Perfect. Thank you guys for those responding that can hear me. Awesome. All right. So lastly, if you have questions on the presentations, please make sure that you enter them directly into the Q&A area. The questions will then be directly responded to once we get to the Q&A portion after the presentation. And then I would also just like to note, if you'll go ahead and go to the next slide for me, that the views expressed in written conference materials and by speakers and moderators for these events does not necessarily reflect the official policies of the Department of Health and Human Services or SAMHSA, nor is that mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. Next slide. All right, so today's webinar is hosted by SAMHSA's 9 Crisis Systems Response Technical and Training Assistance Center. SAMHSA has selected Altarm to provide training and technical assistance support to states, tribes, and territories and community partners across the country relative to the 988 Suicide Crisis Lifeline and Crisis Continuum of Care. Alongside our partners of W2 Consulting and Change Matrix, we have an extensive experience of crisis services and technical assistance, and we are looking forward to providing an awesome event for you today. Next slide. All right, so just a quick overview of our agenda for this afternoon. We will go over SAMHSA's role, the importance of the 988 and 911 interoperability. We'll do an introduction of the risk and liability toolkit, and then we'll also give you guys an opportunity to go over questions and answers. So we will address any questions that were submitted prior to the event, as well as try to address as many questions as possible that come in throughout the webinar. Understanding that we may not get to everyone's questions, but we definitely want to give you guys an opportunity to connect with us afterwards. Next slide. All right, and so with that, I want to pass along the baton to Jill Mays for SAMHSA's welcome.
Good afternoon, everyone. Let me see if I can get my camera working. Okay, there, that's better. Good afternoon and welcome. Thank you for joining us today and for taking the time to participate in this very important conversation. We know that each of you is balancing urgent priorities in your own communities, and your presence here reflects a shared commitment to strengthening how we respond when people are experiencing their most vulnerable moments. The connection between local 988 contact centers and local PSAPs, law enforcement, and first responders is not an abstract or a theoretical work. It's critical, life-saving work. It's work that directly affects individuals, families, entire communities who count on us to show up with care, coordination, and clarity in times of crisis. I'm grateful to be with partners who understand both the responsibility and the opportunity that this moment presents. At SAMHSA, advancing crisis system transformation is a core part of our mission. Through the 988 Suicide and Crisis Lifeline and the Behavioral Health Crisis Coordinating Office, we're focused on building a behavioral health crisis system that's accessible, responsive, and fully integrated with emergency response systems. Improving interoperability between 988 and 911 is essential to that vision, and today's webinar is a part of that ongoing leadership and collaboration. Today's discussion is centered on SAMHSA's new publication, which we're very excited about, 988 and 911, Strengthening Crisis Response While Managing Risk and Liability. This resource was developed to support communities as they work to safely and effectively integrate behavioral health crisis response systems. The framework of the publication offers practical guidance for reducing legal risk, clarifying roles and responsibilities, strengthening partnerships, and improving coordination between 988 and 911. I know that that sounds like a lot for one publication, but it happened. And all of this so that people in crisis receive timely, appropriate, and compassionate care. Importantly, it's designed to move the conversation as we're beginning today move that conversation from uncertainty to confidence and from concern to action. And none of this work happens in isolation. Effective crisis response depends on strong collaboration across behavioral health, public safety, law enforcement, emergency medical services, and community partners, all of us working together. And when these systems work together, when roles are clear, when communication is strong, and where there's trust, then outcomes improve not only for people in crisis, but also for responders and call takers who are asked to make high stakes decisions every day. So before we move forward, I want to pause to acknowledge the very large group of stakeholders and collaborators who contributed to the development of the Risk and Liability Toolkit. Now, this is a long list. I'm just going to say that up front. And I say that very intentionally because it reflects the depth of expertise, lived experience, and countless hours of planning, brainstorming, and dialogue that went into this work. And I want you to really hear the level of input that we had. It's important to name and thank those people who helped bring this publication to life and who will continue, along with so many others, to turn the vision on the pages of the publication into action in communities across our country. First, I want to thank the TTAC, who's hosting our webinar today and who was very instrumental in the development, writing, and formatting and all the things that went into this publication being available for you all today. So thank you to Alterum, to Bree, and the whole team at Alterum. Within SAMHSA, my colleagues, I want to thank Dr. Richard McKeon, who you'll hear from shortly, Dr. John Palmieri, our former 988 director, Monica Johnson, our current acting director, James Wright, and Tiffany Russell, who is our lead in the 988 NBHCCO office on all things criminal justice and behavioral health and 988 and 911 interoperability. Tiffany's your person, and you will hear from her later as well. But I also want to go ahead and acknowledge members of the Risk and Liability Toolkit Advisory Group, and that includes the Department of Justice, Office of Justice Programs, and that was Brooke Mount, Jennifer Mathis, and Marissa Farina Morse. Partners from Vibrant Emotional Health, our 988 administrator, Amanda Miller, David Overfeld, and Mackenzie Simmons. April Hines from the National Emergency Number Association, the Association of Public Safety Communications Officials, the U.S. Department of Transportation's Office of Emergency Medical Services National 911 Program. They were represented by Brian Tetmeyer and Kate Elkins. Michelle Sclater from the FCC Competition Policy Division, Wireline Competition Bureau, and the National Association of State 911 Administrators, NASNA. We had Harriet Rennie Brown and Budge Currier representing that group. So most, if not all of the key players in that space were a part of this the development of this document. But also, I want to recognize the folks who participated in our 911-988 collaboration risk and liability toolkit conversations. And these folks offered their real world insights that help ground this work in very practical experience. So it's not just a high level document, it's a document aimed at really demonstrating what this guidance will look like on the ground. In that group, Melissa Butler from the Wisconsin Department of Health Services, Carrie Simon and Aaron Collenbrock from Dane County Human Services Department, Shaheen Syed and Sandra Kramer from D.D. Hirsch, Wayne Harris from Baltimore City Fire Department, Mike Hatch with the National Policing Institute, Shelley Missall from Family Services of Northeast Wisconsin, and Heather McGaffin from the Office of Unified Communications in Washington, D.C. So this group of subject matter experts was convened on several occasions to inform the creation of tools and resources to improve 911 and 988 collaboration. Through conversations with experts from across the country, the TTAC explored both real and perceived liability risks and the barriers that can impede successful coordination. And all of those insights directly shaped this actionable guidance document designed for implementers, and that is administrators in 988, 911, law enforcement, and community organizations. Implementers, I keep saying that, that's key. Implementers who are working to foster open communication and long term partnerships across the crisis response ecosystem. And I want to close my opening remarks with a brief story that underscores why this work really matters. Earlier in my career, before coming to SAMHSA, I worked as the crisis coordinator in Georgia's call center for SAMHSA's Disaster Distress Helpline, which operates in many ways like 988 to support people during moments of acute crisis. So during a hurricane, I believe it was Hurricane Sandy, an elderly man from Florida called in, and he was terrified that after losing power, his oxygen tank might not last long enough to keep him alive. What do you do with that as a crisis counselor when you get that call? What do you do? Um, so because of very strong coordination and communication nationally, I was able from Georgia to connect with a local law enforcement agency in Florida. They were able to dispatch help. They rescued the gentleman and ensured that his family was contacted as well. So that call has stayed with me, not because it was extraordinary, and it was an extraordinary call, not because I did anything extraordinary, but because it shows what is possible when systems work together. The guidance we're discussing today, the publication we're launching, and the dedication of people all across the country, including those of you who have joined us today, will help to strengthen 988 and 911 interoperability, all to serve one purpose, making sure that when someone reaches out for help, the response they receive is the right one at the right time and delivered with care. Thank you for being a part of this work, and thank you for joining us today. I look forward to the conversation ahead. And with that, I'll turn it back over to you, Bree.
Thank you so much, Jill, for those words. And thank you all for all the amazing work that you guys put into the toolkit and then planning for this webinar. And so with that, we'll go to the next slide. All right. So speaking of all the work that has gone into this publication as well as this webinar, I have the pleasure of introducing our speakers for today's event. I'll start with Dr. Richard McKeon. Richard has spent most of his career working in community health, including 11 years as director of the Psychiatric Emergency Service and 4 years as associate administrator and clinical director of a hospital-based community mental health center. He is currently a senior advisor in the SAMHSA 988 and Crisis Office after serving 12 years as the chief for the suicide prevention branch in the Center of Mental Health Services. We're looking forward to his conversation and dialogue today around the toolkit and how to implement this. Next slide. All right. And alongside Dr. McKinnon, we have Tiffany Russell. Tiffany Russell currently serves as the Chief of Crisis and Justice Initiatives at SAMHSA's 988 and Behavioral Health Crisis Coordinating Office. Tiffany serves as an advisor to the 988 Director and other members of SAMHSA's senior leadership in planning and determining policy, programs, and activities that address complex challenges in coordination with the 988 crisis centers and law enforcement, 911 call centers, and emergency medical service responders. We look forward to the dialogue and the conversation and the information that she's going to share with you guys today. And we'll go to the next slide. All right, so with all of that, what can you guys expect to learn today? And what will you walk away with? So we're going to talk about why this toolkit matters, how to build readiness and improve and incorporate those partnerships. What does trust look like? How this can be integrated into your training and operational next steps. We'll talk about policies, protocols, and risk reduction, as well as provide you some real examples that are directly corresponding to jurisdictional and tribal work. Next slide. Who is this toolkit for? So, most of you guys that are on here are probably in this group, right? So it's for state, tribal, and territorial 988 administrators. It's going to be for our direct service providers, mobile crisis and co-response teams, policymakers, those who are system champions, as well as our state and local 911 leaders and PSAP staff. So most of you guys that are on here, this toolkit is for you and for the work that you're doing across the crisis system continuums. Next slide. And with that, as we transition over to the next slide, I want to hand it off to Dr. McKeon to dive a little bit more into why this matters.
Thank you so much, Pri. It is a pleasure to be with you all today to talk about this incredibly important issue of 988 and 911 interoperability. I've had the honor of being associated with the National Suicide Prevention Lifeline since its launch in 2005 and being affiliated with its development over time, including the full launch of 988 in July of 2022. And it's important to be aware of, and Jill mentioned this as well, that it's 988 is important not only because of the importance of being able to make accessible help to people in mental health or behavioral health crises, including suicidal crises, any time of the day or night, 24/7. That is absolutely critical. But, the goals for 988 are not only to expand access, as vitally important as that is, but also for 988 to be a linchpin for transforming behavioral health crisis care across the country, and being able to be a catalyst for that level of change. In fact, in SAMHSA's report to the FCC, where we first recommended a 3-digit number for suicide prevention and behavioral health crisis care, we indicated that we hoped that 988 could be a catalyst for change in much the same way that 911, over a half century, became a catalyst for the development of emergency medical services in the United States. So in many ways, 911 has really been an inspiration for 988. But the interoperability between these two systems is critical. And the term interoperability connotes a bidirectional relationship. Right? So one of the reasons why the interoperability is so crucial is that we know that very frequently behavioral health crises often enter through 911. And there are important reasons why this is so. One of the reasons that it is so is that so many people, virtually the entire population, know what 911 is and what it's for. We are in the process of helping to build awareness of what 988 is and what it is for. In the most recent study by the National Alliance for Mentally Ill, in survey, about 70% of Americans indicated they'd heard of 988, but only about 30% felt like they were familiar with what it would be for. In our report to the FCC, the analogy that we made was that if somebody was experiencing significant chest pains, that despite the intensity of that emotional crisis, it is likely that both a family member who's with them, as even the person themselves going through that, are going to remember the number 911. But that it was unlikely that in a suicidal crisis, that the number that we were using at that time, 1-800-273-TALK or 1-800-273-8255, would not immediately come to mind for many Americans. So our hope and our goal is that 988 can be top of mind when needed, including in the midst of a suicidal or other behavioral health crises. So one of the most important areas that it has to do with, well, we want people who are thinking about suicide to know that they can call 988, right? That someone who's having suicidal thoughts does not necessarily have to call 911. They can call 988 and be responded to. That's what the National Suicide Prevention Lifeline has been doing for over 20 years, talking to people who are thinking about suicide, who are at risk for suicide, engaging with them, but also assessing their risk, but really trying to come to an understanding of what is driving the pain that they're experiencing that's leading them to have suicidal thoughts. And then safety planning with them, working with them to resolve, to the extent that we can, the issues that are driving their suicidality forward, that are increasing the level of psychological pain that they are experiencing. But it's sometimes misunderstood that while we want to encourage people who are thinking about suicide to call 988, sometimes people think that you have to be suicidal in order to call. That is not the case. We would like people to call as soon as possible. So, for example, and in fact, the Lifeline has always taken that stance that we wanted people to call as soon as possible. So, for example, if somebody was experiencing significant depression and were feeling hopeless, we would not want them to have to wait until they were suicidal in order to call for help. If somebody was experiencing an episode of psychosis or a family member who was concerned about them, we wouldn't want them to have to demonstrate that they were suicidal in order to call. No, we would want them to call as soon as possible. If somebody was experiencing a substance use crisis, if somebody's sobriety was in jeopardy and needed someone to talk to, for all of these reasons, we would encourage people to call 988. But I mentioned that interoperability means a bidirectional relationship. It's also important at times for 988 to be able to reach out to 911 and the emergency medical services system. The most frequent reason for that is a suicide attempt in progress. Now, the National Association of State 911 Administrators has recommended if there is a suicide attempt in progress, that 911 should be called. And we agree with that, that if there is a suicide attempt in progress, we would encourage 911 to be the number that people called. However, the reality is that every single day, multiple times per day, typically, someone who's in the midst of a suicide attempt will call 988. And so when we find out that someone, for example, has in, let's say, the hour before a call to 988 had taken an overdose, we want to be able to connect them to 911 and emergency medical services just as fast as possible, right? And that is the main reason that we would reach out to the 911 public safety answering points. Now, there are other reasons when there's a threat to public safety that might be going along with somebody being suicidal, would be another reason. But it's important to be aware that the overwhelming majority of contacts to 988 do not lead to our reaching out to 911. We have in a number of documents, and Vibrant Emotional Health has put out a really good white paper on this. We estimate that the number of times that 911 is contacted is less than 2%. And the more recent data that I've seen, at least, would suggest that that number, might ultimately be lower than 1% of all the contacts, that we get. So it is relatively rare, but when we reach out to 911, that is a critical outreach there. And that outreach is now helped by the fact that we have what's called geo-routing. Some of you may be aware that for years 988 had connected people based on the area code of their phone. And of course, nowadays people move, they take their phone and their phone number with them. So it's not really a good guide to where somebody might actually be. Now, 988 does not have the kind of geolocation that 911 has, where you can more pinpoint somebody's location. But geo-routing operates through the cell phone towers that the cell phone call needs to go through. So it allows us to connect to the community that the person's in, not the specific location, including that also helps our 988 center reach out to the correct 911 public safety answering point there. So again, just to emphasize that the importance of the bi-directional nature of the need for interoperability between 988 and 911. So 988, as I said, has long provided specialized crisis response, working with suicidal people. So long history of evaluations of the Lifeline 988 that shows that the calls and the chats can reduce suicidal ideation. And in fact, it also shows that in a significant majority of instances, even those people who are at imminent risk for suicide, that is, those people who the concern is that they may act on their suicidal ideation in the very near future, that a significant majority of it can have their risk reduced such that 911 does not need to be contacted. So we want to be able to make sure that our colleagues in 911 and the emergency medical services system are not overloaded by mental health calls, behavioral health crisis calls, that in fact 988 could be able to handle. And what people receive in essence is crisis intervention when they call 988, an effort to make a good connection with them, to understand what's driving their pain, to be able to problem solve with them what might be able to be done to reduce that pain, and to connect them to needed follow-up services, are all things that are part of the specialized crisis response. But also, because SAMHSA's goal is not only to have someone to contact, but to be able to have someone to come to you when there's a need for a face-to-face response. SAMHSA's goal has been to promote the utilization of mobile crisis services across the country. Now, we're aware that not every community has access to mobile crisis currently, but our goal has been to promote that as much as possible so that calls can go from a 988 call center to mobile crisis without having to involve the police and without having to involve emergency medical services, again, in those circumstances where there's not a suicide attempt in progress, where there has not been a threat to public safety. Now, this kind of bilateral coordination can improve outcomes and can improve safety. And that is, of course, what we all want is for people to keep people safe, but also to help reduce the underlying pain that's driving um, their suicidal thoughts or other behavioral health crisis services. And on the other hand, fragmentation increases the risk both for callers and even for responders as well. You know, the first trip that I made after once uh, the pandemic abating allowed for travel was to visit two state-of-the-art programs that focused on 988 and 911 interoperability. One was to Los Angeles for the program between the D.D. Hirsch Center, the nation's actual first suicide prevention center. And they have a program with the Los Angeles Police Department where calls were able to be transferred that came in to 911 that were answered at the Police Communication Center were transferred to D.D. Hirsch according to a set of excellent criteria that were developed. And they found that very few calls needed to be returned to 911 so that safely those calls could be warm transferred from one system to the other. And there are other places as well that have utilized, this model. I think a behavioral health response in St. Louis has used a similar model with public safety answering points in that area. The second place that I went to visit was in Harris County in Houston, Texas. And in Harris County, the Harris County Mental Health Center has staff embedded in the very large 911 public safety answering point for Harris County in the city of Houston. And so there you had mental health staff embedded right in the PSAP itself to work on helping to divert from having a full 911 response. Many of us have frequently seen, as we're driving along in our daily routines, we'll see things where there are multiple police cars, fire department vehicles, a tremendously costly response that is not necessary if someone is thinking about suicide, but they've not taken action in order to end their life, where they would need emergency medical services. So having someone embedded in the 911 PSAP is a wonderful model. Not feasible everywhere. There are many more PSAPs than there are 988 centers. But for those places where it is possible, it is a really important kind of approach that could be utilized. Also in Texas, in Austin, Texas, they've taken that model actually a step further. And if you call 911 in the city of Austin, you hear a request where you're asked the nature of your emergency. Is it police? Is it fire? Is it emergency medical? Or is it mental health? And then that call gets directed to the mental health person. So there are numerous ways for 988 and 911 to operate together and to be coordinated. And in my judgment, this is one of the most important areas for focus moving forward in the continuing development of 988 to make sure that those connections are supported and that communities can have 988 and 911 working together on behalf of all the members of their community. We can go on to the next slide. Okay, thanks. So SAMHSA actually has a range of publications that we have developed in order to promote these kinds of coordination efforts. There is the 988 and 911 Partner Toolkit. There's a 988 and 911 Key Differences fact sheet. Um, um, an additional publication on advising people on using 988 versus 911, practical approaches for healthcare providers. That's an effort for healthcare providers to give them some concise, straightforward ways to communicate to people that they're seeing regarding when to use 988 versus 911. And this is also embedded as part of our National Behavioral Health Crisis Care Guidance, which is an extraordinarily important guidance document from SAMHSA, designed to help promote the kind of continuum of care and coordinated care that we've been talking about on this webinar today. But we've also collaborated with other organizations. So I'd call your attention, if you are not familiar with it, to the National Emergency Number Association, standard for 911, 988 interactions, focused on coordinating the role that coordination can play in improving outcomes and safety. I was pleased to be able to be part of the working group that Nina utilized to develop these standards, as well as many other experts from both the behavioral health field and the 911 world as well. And one of the things that's emphasized in the NINA standards is the importance of that local level communication and coordination between 988 and 911, right? And that kind of local coordination is starting to happen in various places across the country. I've talked about some of the models already, but there are also statewide efforts that have gone on. A year ago, I was visiting Indiana, and I was very impressed to learn that there's a statewide effort to improve coordination and communication and data sharing between the 911 PSAPs in Indiana and the 988 call centers. And a number of other states have done similar things to try to promote that level of coordination. Ideally, we'd be at a point where both de-identified data could be shared so that people would have a sense on both sides of what the outcomes were and the importance of the collaboration. But also, if there were adverse events, that there would be able to be communication between all parties in the community response system, in the community crisis response system, about what happened, if something went wrong, what would be needed. Usually when things go wrong, it's because of a systems issue, not because of an individual failure. So the issue of how systems communicate with each other, whether you're talking about a 988 center, mobile crisis stabilization units, emergency rooms, law enforcement, EMS, fire, etc., that coordination is critical because we don't want anybody to fall between the cracks because of fragmentation. Right? So our goal is to reduce the fragmentation, improve the coordination and the collaboration of working together to keep Americans safe all across the country. That is what the goal is. And we are very glad to be able to be part of this webinar today. So that is it for me. I don't have to take the entire time I was allotted because that'll give us a little bit more time to Q&A. So Tiffany, does it go to you next or does it go back to Bree?
It goes back to me. I'm ready.
All right.
Thank you so much for providing that background information, Richard, for everyone that joined the call. And again, thanks to everyone who came today for getting information about this risk and liability toolkit. When we're talking about why this toolkit was created, I want to start off by saying that it has taken approximately 3 years for us to get this publication aired. And about 2 years of that time was really just the writing, collaboration, listening to experts, talking to the states and jurisdictions about what it is that would be helpful to them if they were in the beginning stages of planning 988 and 911 collaboration or interoperability. A year of that time was spent really just talking and listening to all of the challenges and obstacles that people faced in their communities when they were talking about 988 and 911 collaboration, and how could we be of assistance and help to provide them with the tools that they needed. And as we learned and listened with those collaborators, one of the main themes that kept coming up was about liability. What we also learned was that liability was meant to be a stopper. It was meant to be a wall. It was meant to be a blockage to keep the collaboration from moving forward. And a lot of that was just around fear, fear from your legal aspect for your community, thinking about what kind of liability that meant for them, fear from partners who have not done this before. This is all new to them. You're talking about changing systems, changing protocols, changing the way that the system has operated for a number of years. And the easiest way to do that is to start bringing in legalities and talking about risk and liability. And that's oftentimes a great way to stop the conversation from moving forward. We did not want this toolkit to be law school in a book. And so you are not going to get a full legal eagle information and be a lawyer or a paralegal when you get done with this. It was meant to be for the everyday implementer who is working within the system to collaborate around behavioral health and the justice system, law enforcement, and emergency medical providers. And so we did not want to use language that was going to be overwhelming to you. We did not want to bog you down in a lot of legal terms, but we did want to make sure, as our title stated, to take you from concern to confidence. And so we wanted to give you enough information so that when you had those conversations with your collaborators, when you had those conversations with stakeholders about how do we get started, how do we start working to start bringing our system together to work more closely with one another, that when you heard that term about liability, or when you started to hear about risk, that you didn't feel so conflicted about continuing that conversation, and that you started to have some tools that were given to you about how to work around that conversation and say, well, actually, HIPAA doesn't keep us from having this connection between our agencies. And so that's one of the reasons why we put this resource tool together, is because we wanted to give you enough information that you could feel confident and to continue those conversations when you started to hear this from your stakeholders. So again, a lot of the concerns that are being brought forward when we're having those conversations are really just perceived and not necessarily based in evidence. And we have to make sure that when we're having these conversations that we're really looking at the evidence. And if there is evidence of liability concerns, that there's still a way to work around that with protocol, with assessments of our readiness of the community, looking at MOUs and service agreements amongst agencies. Again, there's still a way that we can continue to have that conversation and to move this process forward. So again, the jurisdictions were asking us to provide them with something that was practical, something that they could use. And just speaking as a former implementer in a community, we also wanted to make sure we gave you something that wasn't 300 pages long. We wanted this to be something that was easy to use, something that you could keep around with you, carry around with you, and use it as a tool that you kept handy with you when you're having these conversations around collaboration. So what you'll continue to hear throughout this webinar today is really talking about trust and clarity and risk management and what that looks like and sounds like as we continue to have this conversation around collaboration. Next slide. So I think one of the things that if you have been working in behavioral health alongside justice communities for a while, you've probably heard about violations related to HIPAA. You've probably heard things around negligence. You've probably had some concerns around what happens when calls are being transferred. And I'm sure that you've had some conversations around agreements, and now we're talking about legal documents and what that all looks like. Again, what we are hearing is not anything that we haven't heard before. Back when I think if you've been around since probably 2012 or 2013, around the time that the Stepping Up initiative got started, one of the major conflicts that we heard about amongst sharing information about a particular client or a particular patient amongst the justice system, the justice system to the behavioral health system, as well as the medical system if they were involved with the hospital, is are we going to be able to share information about this person and still keep it confidential and not go against their privacy? How can we do that? And HIPAA doesn't keep you from sharing that information, but it does provide you with the steps that you need to take in order to do that and do it safely and do it appropriately. And so, again, some of those concerns that you hear about as far as HIPAA violation around negligence, it requires the community to sit down and make sure that you're talking about these processes and putting protocols into place, putting agreements into place to protect not only the client or the patient themselves, but also protect the community members, the stakeholders, the providers that are trying to improve this system for those individuals. Again, a lot of the outcomes that we have found are not necessarily based in any legal precedents. When we started the research for this particular resource tool, I think we came across maybe 2 cases where someone brought up a negative outcome that happened to them as it relates to a behavioral health crisis and related to the systems that they were involved in. And so it's not very documented about negative legal outcomes. But again, it's about the fear of having that. We don't want that to happen. We don't want that to happen into our community. And so we are, again, oftentimes putting up hazard signs and blocking that conversation from moving forward because we don't want to take on that additional risk that might come along with that. But oftentimes what we have found is that risk is most increased when the systems aren't coordinated. The negative outcomes actually happen when the systems aren't talking to each other. The failures happen, the people fall in the gaps when they are not involved in a system that actually coordinates and talks to each other. If you think about the example that Jill mentioned when she started this, when she gave her remarks, what would have happened if she did not have the ability to connect to that particular state's infrastructure? What if she didn't have the ability, if she didn't know what resources to use to connect to someone in that state, being that she wasn't in that area? What would have happened to that gentleman if there was no way for her to make those connections? And so that's where the risk actually lies in. It doesn't lie within the realm of we actually are talking to each other. We're breaking the silo. We're actually coordinating our efforts. We're actually drawing out what those protocols look like. That's not where the risk actually lies. It's when we're not talking to each other, when we're avoiding that connection, and when we're trying to operate within our own systems to do everything, and we start doing things that are outside of our actual wheelhouse. So before we move on and start moving on to the next section, I want to ask a poll question. And so I'm going to give a second before that poll question pops up. But what I want you to think about is what concern most limits the progress in your jurisdiction. What is it that you're actually, what actually is hindering you from continuing that progress? Is it actually HIPAA and information sharing? Is it negligence or the liability exposure? Is it the workforce capacity that you're thinking about? Or is it governance and contracts? So what is it that's happening in your community that you feel is hindering the progress in your jurisdictions? And I'll give you guys a second to answer that particular question. And I don't know if the results are ready yet, but again, just really thinking about as you're answering that question, is that perceived or is that real as well? So it looks like, based on the answers that we've received so far, that 38% of you are saying that workforce capacity is actually the concern that is limiting the progress in your jurisdiction. 15% answered that it was around HIPAA and information sharing. 26% is saying that it was negligence and liability exposure. And 21% is saying governance and contracts. Okay, great. Thanks for sharing that. Now, as we're moving forward to the next slide, I want to start talking about what that looks like around your key partners that matter. Now, we have been talking about collaboration in 988 and 911 for quite a bit. But what does that actually look like when we're inside of a community, whether it's a state, county, local community, that is putting this information together and they're trying to move forward with 988 and 911 collaboration? What you're going to see is that you can name quite a few of the key players that need to be a part of that right off the top of your head. So if you're talking about 988 and 911 collaboration, of course your 988 and 911 leadership should be a part of that conversation. You're probably going to start with some of your state and territorial or tribal authorities. You're for sure going to have a behavioral health and your mobile crisis providers there for that conversation. Here's where some of the silo starts to come in. A lot of times we do not include our law enforcement partners, our EMS partners, and our fire department partners in those conversations, mainly because we don't necessarily that doesn't necessarily come to the forefront when you're thinking about behavioral health. But if you're contemplating collaboration between 988 and 911, if you call 911, that gives you direct access to the police, fire, as well as an ambulance. And so depending on who is available is who's going to show up in that behavioral health crisis. And sometimes it's the fire department that gets there first. Sometimes it's the ambulance that gets there before the police. And so it is important to also have them present and accounted for these particular conversations. But the person that's the most important when you're trying to bring these partnerships together is a person with lived experience. And I think we can all assume why that would be the case. You want to listen to a person who has gone through or a person that has dealt with this in their own personal life, someone that can provide you with a firsthand response to what this looks like when it's happening to them. And that's the only way that we, one, can improve their response, and two, it's the only way that we can get the actual information about what this looks like in order to prevent this from continuing to happen to that particular individual. I also want to state that when we're talking about bringing these partners together, it's almost like bringing together the United Nations. We are all not speaking the same language. We all often have our own interpreters that are with us that speak the language that we speak, but they're having to interpret this language to the others and that are bringing this information together. And so sometimes when we're talking about crisis, we're not all saying the same thing. We may all say crisis, but behavioral health crisis and a fire crisis and a crisis for emergency medical providers and crisis for law enforcement are oftentimes four very different definitions. They're not the same. And so one of the things that we always want to do when we're talking about bringing your key partners together is to make sure that we're bringing along with us shared definitions, and that when we are starting to have these conversations that we are talking about the same thing in the same instance, so that as we move forward, there is no miscommunication about what one group means when they use a particular word, and crisis being one of the main ones. That also comes down to risk for them as well. What does risk look like for the police versus what does risk look like for 911 operators? What does risk look like for a 988 crisis counselor? What does risk look like for a 211 provider? And that is, again, going to be very different than when you're talking to a fire person or someone who is operating an ambulance about what crisis looks like. Those terms we use them interchangeably, but the definition for them is going to be very different in each instance. Next slide. And so once we've had that conversation about shared definitions and we're getting that started, then it's time to start talking about what are we actually ready to do? What is it that we're here to do? Again, I think when we are talking about 988 and 911 collaboration, especially for this particular office, when I first started here, I think oftentimes a lot of folks thought that 988, 911 collaboration meant to them 988 and 911 integration, and that is not necessarily the case. What we are saying is that we're not mentioning, now it may work for Harris County, and that's great. We love that idea, but there is no one size fits all for every single community. But we don't necessarily mean when we're talking about collaboration or interoperability that 911 or 988 are going to cancel each other out, they're going to replace each other, or that one is going to be working inside of the other. Simply what that means is, are we ready to sit down and talk about how we can connect and ensure that folks are not falling in the gaps? And so when we're talking about, are we ready for that change and are we ready for this conversation to actually happen and move forward, we really need to sit down and discuss in that group of stakeholders, that partnership stakeholder group that we just discussed earlier, what exactly are we looking for and accomplishing within our community? Now, I'll say that when we're talking about putting together an assessment for readiness, I don't necessarily mean a matrix or a checklist, but that is helpful. And we do have some examples within the toolkit that you can look at to kind of help you go through that process. But what it does mean is that we need to sit down as a community and really define the purpose and the scope for what is going to work in our community, because there is no one size fits all. It is great to have states and other communities that we can look at as examples and that we can bring in information from. We can have their experts to come in and talk to us and really help us describe what they were able to accomplish within their community. But it's really important that you sit down and think about very specifically what will help in your community and what will help in the community that you're serving in. One of the things that I have come to understand that in talking to a lot of states and communities is that the same group of people that we are helping within behavioral health are oftentimes very well known within the law enforcement community. They're also well known within the 911 community. They're also well known within the ambulance and fire departments, because these are the folks that are on the streets. They are the folks that we are helping often. Most times they're using a lot of the resources within the community, and we actually all know them, sometimes by name. And so you want to make sure that because you know these people, you know what they need, you know what you get between the interactions that you have all had with that particular person or those individuals, you know what's important for providing care to your community. So it's really important that you sit down and define for yourselves what is the purpose and the scope for what our collaboration is going to look like, not necessarily what it looks like in California. You also want to make sure that it's that you are identifying the resource gaps. The poll question, I think, kind of showed that very quickly. Workforce capacity is going to be one of the major things that we have as it relates to what we can accomplish in any type of collaboration or interagency work. And so it's really important that you take that time to look and see what kind of resources that you have and where you're lacking in those resources as well. Of course, we're also going to assess leadership and sustainability, but I think those things are clear. And the only thing that I want to say about when you're assessing leadership, what's more important than leadership is identifying a champion, because identifying that champion for your system particularly is going to be that person who can speak to law enforcement, behavioral health providers, your city or your county leadership. They're going to be the folks that can talk directly to your providers as well, and really rally around the collaboration that is needed. And when you have those tough conversations and those tough times that are for sure to come, having that champion is really more important than really determining a leader for that group. Next slide. So we also want to discuss, what does that look like when we're starting to build the trust amongst this particular group? Of course, having those conversations early, and not only having those conversations early, but having those conversations early with everyone present. It's not helpful when you've already started having those conversations amongst yourself, and it's just 911 and 988 having that conversation, and then you've already started making decisions, and now you want to bring law enforcement. It tends to create more of a silo and really leans away from the partnership that could come forward in that particular area. So you want to start those conversations with all of the partners present in the very beginning, and you want to start that early. You want to make sure that you're clearly defining the roles and the responsibilities, because again, we're not asking 988 and 911 to take on the jobs of the other. But what you are trying to do is to make sure that you have a very clear understanding of what each one of those partners are doing and what they bring to the table. It's also helpful and important to bring and use your workflow charts and your decision matrix to help the partners understand how decisions are made within your own agency. And so it helps with 911 if they can understand what will trigger in 988 a call to 911, or for what will trigger a call or to transfer that call over to law enforcement for 988. And it's important for 988 operators to understand what type of information a 911 PSAP operator needs when they get a call coming into them from 988. What's important? What's the information that you need to have? And so it's really important that we have those workflow charts and decision tracks available so that they can understand from each side what's happening. And then again, maintaining consistent communication the entire way is going to be important as well. Next slide. So you also want to think about using tools that help to build trust, along with having that clear communication and bringing your collaborators in early. MOU is a great way of doing that. It really makes sure that you have the same shared expectations about what needs to happen. You've clearly defined the roles and the responsibilities for each entity and what needs to happen in an interaction. And so that way everyone knows where they stand and how they're moving forward. This again supports that early stage collaboration because everyone is clear about how things should move forward and how things are happening. And then again, it also starts that groundwork for how you can continue to move forward, whether a service agreement is needed or other things are needed to be put into place to protect those stakeholders from risk and liability exposure. Next slide. So Understanding with cross-training, this is one of the things that we've mentioned oftentimes when we're talking to states and communities about collaboration, is bringing in cross-training. Again, what we're not trying to do is we're not trying to make 988 crisis counselors become 911 PSAP operators and vice versa. We're not trying to train 911 into how they can manage behavioral health calls. That's not the case in what we're trying to do as it relates to cross training. What it does do is to help with role confusion. And then it provides you with clarity around what the responsibilities, what happens in these agencies, how they make decisions, and it gives you an understanding, because there are, as Richard mentioned, while 911 is widely known across the country, 988 is still on the climb of becoming more popular and aware. And so a lot of 911 operators don't know what 988 is and how it works. And so that will lead to fear of collaborating as well, because they are unclear, they're unsure about what that means and what it is. And so let's stick with what we know and what we have versus talking about bringing in a new service. And so cross-training can look like de-escalation training and crisis identification, having sit-alongs and ride-alongs with law enforcement and 988 crisis counselors being in to listen in to a call. And then really having, again, that shared understanding of the systems and how they work. But again, we are not trying to do a dual role staffing when we're talking about cross-training. Next slide. So when we're talking about risk assessment and your triage framework, each agency, each entity is going to have their own, again, definition for what low versus mild risk looks like. What does higher risk look like? What does moderate risk look like? In the resource tool that we provided in the toolkit, we give some generic definitions for what this looks like and what we think it looks like. But what the community and the group itself needs to determine for itself and their community, again, because you know the folks that are in your community, you know the individuals that you are working with. And so you will have to determine for yourself that when you state high risk, and that means imminent danger for self and for others, what does that mean? Does it mean a weapon is involved? Does that mean something is an incident is already escalating, that suicide is in progress? What does that mean? Are other individuals involved? And that definition needs to happen for your community in order for you to assess liability as well, and the exposure for liability for your agencies. We again give you a framework or a diagram there that can help you think about it. But again, this is a conversation that you need to have amongst your own partners as well when you're thinking about this as well. Next slide. Something that we don't often talk about when we're thinking about collaboration and risk is the risk to staff and the responders who are out in the field working in this particular area around behavioral health crisis. And so, of course, there is, when you're thinking about 988 operators and 911 operators, the compassion fatigue and the burnout that occurs when you're constantly listening to these types of calls that you receive on a daily basis for a 10, sometimes 12-hour shift, sometimes even longer than that. And so you also want to think and make sure that the liability that you're being exposed to is not based on your staff and your responders. And so you want to make sure that you are bringing forward and having in place your employee assistant programs, that you're doing that critical incident debriefing afterwards, and that you're making sure that you're taking care of the psyche of your responders and your staff as well, because that is a lot of where risk is involved in that space as well. Next slide. So as we're talking about making sure that when we're working to improve collaboration amongst in our community, some of the ways that we can make sure that we're doing a continuous improvement in this space is that we're not going to know all of the answers up front, and we're going to be operating, because crisis is a very gray area. It's not going to look the same every single time. Crisis in this community is going to look different than crisis in another community. It's going to look different for every single incident that happens. And so the only way that we can be prepared for all of those instances and really have an understanding of what is needed in our system to move it forward is to make sure that we are doing those quality assurance and audits, that we're looking at incident reporting and we're doing the reviews of those incident reports, and not just of the bad ones, of the really, really bad ones that have a negative outcome at the end, but that we're really looking at all of them, and how can we improve some of what we think are lower risk incidents that are happening, and make sure that those calls don't even come into a 988 or a 911 in the first place. How can we make sure that the community is aware of the resources that it has via a 211 or what have you, that make sure that they're not even becoming involved into these processes because they're not aware of what resources are available. Making sure that we are sharing data across our systems. And yes, there is a way to do that without violating HIPAA, and talking about those reoccurring clients or individuals that we are both that we are both coming across in our daily work, and making sure that we are sharing that information so that we can be better prepared for the next incident, or that we can perhaps curve that incident and make sure that it doesn't happen again for that person again, so that they are not a reoccurring person in our particular systems. And then also making sure that we're learning the culture of our particular community and amongst our stakeholders, and the folks that are working together in that particular collaboration. Next slide. So we provided with you, again, with some examples of how some states are providing service. And as I've mentioned in this webinar before, making sure that you're always doing what works best for you and in your community specifically. But we do want to share with you that there are states and counties and jurisdictions that are really taking the effort for collaboration and really running with the ball here, and making sure that they are providing coverage not only for the stakeholders and the providers that are in their areas, but really being very clear about the protection that comes along with that. And so they're introducing legislation. We have examples of those, that the legislation within the toolkit. So let me just pause and say this, that a lot of the information in the toolkit is, yes, there's a lot of written information there, but we have included tons of hyperlinks that will take you to other areas and other examples, and really show you, so you can do more in-depth research on your own, because there was no way that we can include every single thing and not make it 300 pages. And so there are links to where you can read these bills for yourself, that you can do more investigation on your own about how they got that process started, how they worked to get the legislation passed. And so some examples of that is in Washington, they expanded the liability protection for not only their 988, but for their 911, mobile crisis, as well as their dispatch staff acting in good faith. In Kansas, they created the LIVES Act that provides immunity specifically for their crisis service providers. And in North Dakota, they passed a civil liability protections that extended not only to 988, but also to 211, as well as 911 employees. And so in the risk of liability toolkit, you'll see examples of those bills within that document, if you would like to learn more about what those protections look like, how it's worded, and the work that it took to get that legislation passed. Next slide. So, of course, there is a lot that is happening within our states and communities, but the tribal nations are also experiencing all of this as well for themselves. And so we put some information in this risk and liability toolkit, again, that really helps you understand that if you have a tribal community that you are working with, or if you are a tribal community, a tribal nation yourself, that you have the considerations as well for what this work can look like for you individually. And again, if you are a community that is working alongside a tribal nation or you have a tribal community, we also provided information for you that is going to give you some more information about how to work around sovereignty and jurisdiction, what it looks like when you're crossing jurisdictions, and how you can make sure that you have agreements in place to ensure there's a continuity of service as well when you're working there. Next slide. So I know that this was a lot of information coming at you pretty quickly. I know that there is a lot of questions that you may have had. What I want to implore and really want to emphasize to you is that, again, this resource tool provides you with conversational, easy information that you can share not only with other stakeholders, but for yourself, and make you feel a bit more confident when you're having these very complex conversations with attorneys, county attorneys, city attorneys, when you're having these conversations with other law enforcement partners, so that they can start to understand that the risk and the liability that they're perceiving is not necessarily real. Not saying it doesn't exist at all, but just that there is a way for us to work around it. There is a way for us to collaborate and continue to collaborate. And because I think that the Alterum and the writers of this toolkit, along with all of the feedback that we received from our key advisory groups, as well as those subject matter experts, that I really want to make sure that you're sharing this toolkit with a new partner, that you use those readiness and risk tools that are involved and embedded within the toolkit. And that if you still have more questions, if you still need more help and need more assistance within your community to really get the conversation started, or if you hit a bump in the road, that we are here to provide you with follow-up and technical assistance. And you are more than welcome to schedule that technical assistance and follow up with us. And we'll be more than happy to help you as best we can. But we think that this toolkit is a great start for continuing that conversation. And I just want to make sure that I also give a shout out to the Alterum team, Bree and Jasmine, and the writers, Stephanie and Dana, all of the folks that worked on this. And as well as the folks that have been listening to me talk about putting together this toolkit for the last 3 years. I appreciate your patience, and I finally made good on my word to get this out into the community. And so with that, I'm going to turn it over to Bree and let us open it up to answering some of the questions that we received during registration, as well as some of the questions that may have come in during the chat.